Hello and welcome! Today, we're diving into a super practical, clinical guide to the low FODMAP diet. We're gearing this specifically for medical trainees, to really help you get a handle on what can be a really effective but kind of complex tool for managing irritable bowel syndrome.
So why are we talking about this? Well, get this. A staggering 10 to 15% of adults are walking around with symptoms of IBS. That's huge. It means you're going to see this in your clinic a lot. So having a solid grasp on how to manage it is absolutely essential.
So what are we actually dealing with here? With IBS, it's not like you can find something wrong on a scan. It's what we call a functional disorder. Basically, a communication breakdown between the brain and the gut. And that's a really key distinction because it tells us why our treatments, like diet, focus on managing how this whole system works together.
Okay, before you even whisper the word FODMAP, this slide is your most important stop sign. These are alarm features. They are not typical for IBS. If your patient has any of these, you need to hit the brakes, think about other, more serious diagnoses, and get them a referral to GI pronto.
You know, it's really tempting to jump straight to the complicated diet, but honestly, that's a mistake. The low FODMAP diet is a great tool, but it's not where we start. Good IBS care is built on a solid foundation, and that's where we have to begin with every single patient.
So before we even talk about restricting food, we focus on these 4 pillars. I'm talking about building a real, trusting relationship with your patient, encouraging things like regular walks, making sure they're getting good sleep, and even thinking about behavioral therapies. These things alone can make a huge difference. All right, so when we do get to diet, we start simple. This table lays it out perfectly. The traditional IBS diet is our go-to first-line approach. It's way easier to follow. The low FODMAP diet, that's our second-line tool. It's more powerful, but it's also a lot more involved.
And that traditional advice is pretty straightforward. We'll often recommend adding some soluble fiber, like psyllium, and cutting back on the classic gas-producing foods. Things like beans, cabbage, that kind of stuff. For a lot of people, this is actually enough to really improve their symptoms.
But what happens when those first steps just aren't cutting it? Well, that's our cue to bring in the main event, the low FODMAP diet. This is where we get much more targeted and systematic about figuring out exactly what's triggering a patient's symptoms.
So what in the world are FODMAPs? It's just a funky acronym for a specific group of short-chain carbohydrates. The most important thing to remember here is that they're poorly absorbed. So instead of getting digested like normal, they keep on traveling down the gut, and that's where the trouble starts.
So here's the first part of the 1-2 punch. Because these little molecules aren't absorbed, they're osmotically active. You can think of them like tiny sponges, just pulling extra water into the intestines. And all that extra water, that can lead directly to things like diarrhea.
And here's the second hit. Your gut bacteria see these undigested carbs arrive and, well, they have a feast. They start to ferment them really quickly. And what's the byproduct of fermentation? Gas. In a gut that's already sensitive, all that extra gas leads straight to bloating, cramping, and pain.
Okay, knowing the science is great, but how do we actually put this into practice? You've got to understand that the low FODMAP diet isn't just about avoiding a list of foods. It's a structured, 3-phase process that's really a diagnostic tool to pinpoint a patient's personal triggers.
So here are the 3 phases. First, you have a strict elimination phase for about 4 to 6 weeks. The goal here is just to get symptoms under control. If that works, you move to phase 2, reintroduction. This is where you carefully, systematically bring back each FODMAP group one by one to see what causes a reaction. And the final goal is personalization, a long-term diet that's as varied as possible, where you're only avoiding your specific triggers.
To make this real for patients, examples are everything. It's not about deprivation. It's about making smart swaps. So instead of wheat bread, maybe you have rice crackers. Instead of an apple, you have some strawberries. And instead of regular milk, you use lactose-free milk. These are the kinds of simple changes that make the diet doable.
If you remember one thing about putting this diet into practice, please let it be this. This diet is complicated and it's restrictive. Referring your patient to a dietitian who's trained in this is the absolute gold standard. They make sure the patient does it right, does it safely, and doesn't end up on a super restrictive diet forever.
Okay, so we've covered the what, the why, and the how. Now, let's just boil it all down to the most important, high-yield takeaways for you to bring into your practice.
So the bottom line, does it actually work? Well, yeah, the evidence is pretty strong. As this chart shows, when you look at meta-analyses of good quality trials,
patients on a low FODMAP diet are about 1.5 times more likely to report feeling better than patients on other diets. It really does make a difference.
All right, let's wrap this up. Here's what you need to remember. First, this is a short-term diagnostic tool, not a forever diet. The goal is always personalization. Second, it seems to work best for patients struggling with bloating and diarrhea. Third, if there's no improvement after the elimination phase, stop. The problem probably isn't FODMAPs. And finally, say it with me, dietitian-led guidance is the gold standard.
And let's end with a look ahead. The low FODMAP diet is one of our best tools right now for sure, but it's probably just the tip of the iceberg. As we learn more and more about that intricate gut-brain connection and the microbiome, just imagine how we might be able to create even more precise, truly personalized diets for our patients. It's a pretty exciting time to be in this field.